Hello, my name is Gustavo San Roman, and I would like to thank you for taking the time to view this presentation. Validation proves that the Birthrisk Cesarean Birth Measure is accurate, and can therefore be used to evaluate the labor management strategies being used by obstetrical care providers at different hospitals. I started by looking at only nulliparous women in labor in New York State. I found that the hospital whose patients had the highest inherent risk had a cesarean birth rate of 22.29%, and the hospital whose patients had the lowest inherent risk had a cesarean birth rate of 13.99%. With our current standards, it appears that the hospital with the 13.99% cesarean birth rate has labor management strategies that result in fewer cesarean births than the hospital with the 22.29% cesarean birth rate. This will lead women to believe that their risk for a cesarean birth will be much less if they go to the hospital with the 13.99% cesarean birth rate. However, the Birthrisk Cesarean Birth Measure reveals a very different picture. The Birthrisk Cesarean Birth Measure reveals that of these two hospitals, it is the one with the higher cesarean birth rate that is using labor management strategies that were better at decreasing the inherent risk of their patients. Therefore, if a woman wants to go to the hospital that is best at decreasing her risk of a cesarean birth, then she should go to the hospital with the 22.29% cesarean birth rate. The Birthrisk Cesarean Birth Measure is currently the only measure available that can adjust a cesarean birth rate to reflect the inherent risk of the women who are giving birth. Unfortunately, now that you are aware of how important the concept of inherent risk can be, and how it is used to create the Birthrisk Cesarean Birth Measure, it is time to turn some of your current thinking upside down. Prior to the Birthrisk Cesarean Birth Measure, obstetrical care providers determined the effect of a labor management strategy by conducting a scientific study where similar groups of women were used and where only one group was exposed to the labor management strategy that you wanted to study. If the cesarean birth rate was different between the two groups, then the labor management strategy was believed to affect the risk of cesarean birth. So I decided to do a study, and I started with two groups of women that contained 2,000 births in each group, and each group was represented by approximately 1,000 different obstetrical care providers working out of 100 hospitals. Note that all births were to nulliparous women in spontaneous labor. For this type of study to be effective, you need to confirm that the two groups being studied were similar, and this is done by looking at the average values for the risk factors in each group. As you can see here, my two groups have similar fetal weight and initial body mass index. My two groups also have similar maternal age, but the study group has a slightly greater average maternal weight gain, which may lead this group to have a higher risk for cesarean birth. The two groups have similar average maternal height and average gestational age. It would appear that I have two similar groups of women and that any difference in the cesarean birth rate would come from the labor management strategy that is being studied. And as expected, the study group has a significantly different cesarean birth rate. So therefore, we come to the conclusion that the labor management strategy being studied decreased the rate of cesarean birth. But wait a second. What was the labor management strategy being studied? The problem with this study is that there is no difference in the labor management strategies applied to the two groups. So why is there a statistically significantly different cesarean birth rate in the study group, you might ask? Well, that has to do with how I created the two groups. The control group was created by combining younger women having smaller babies with older women having larger babies, and the study group was created by combining younger women having the larger babies with older women having the smaller babies. I created these two groups in this fashion to illustrate that having two groups of women with similar average risk factors does not necessarily confirm that the two groups had the same inherent risk for cesarean birth. This is because inherent risk is dependent on each woman's unique combination of physical characteristics and not the average of the group. As you can see here, my software was able to determine that these two groups had different inherent risk. So when you read a study about whether or not a labor management strategy increases or decreases the risk of cesarean birth, ask yourself if the two groups being studied had the same inherent risk for cesarean birth. And remember that having similar average values does not necessarily mean that the two groups had the same inherent risk. If the inherent risk of two groups being compared is different, as we have here, then only the Birthrisk Cesarean Birth Measure has the ability to determine if the labor management strategy applied to the study group significantly affects the risk of cesarean birth. As you can see here, the Birthrisk Cesarean Birth Measure for each group was the same, which is what you would have expected since the two groups did not have different labor management strategies. This study illustrates how the Birthrisk Cesarean Birth Measure is able to measure applied risk regardless of the cesarean birth rate or inherent risk of the patients being studied. This is really important, so I'm going to say it again. This study illustrates how the Birthrisk Cesarean Birth Measure is able to measure applied risk regardless of the cesarean birth rate or inherent risk of the patients being studied. This can be further illustrated by looking at the four groups which were combined into a control group and a study group. This table represents the four initial groups used to create the study. Note the very different cesarean birth rates and very different inherent risk for each of our four groups. Also note the very similar Birthrisk Cesarean Birth Measure for each group. Once again, this illustrates the ability of the Birthrisk Cesarean Birth Measure to be used in any population of patients, and it is this ability that can empower every obstetrical care provider with the ability to find the labor management strategies that can safely decrease the cesarean birth rate. So now you know that it will take the concept of inherent risk and the Birthrisk Cesarean Birth Measure to get the world of obstetrics right side up. I would like to thank you for taking the time to view this presentation.